Chapter 18, we're going to talk about alterations in cardiac function. We're going to start here with coronary heart disease, or CHD, also called ischemic heart disease or coronary artery disease. It's basically characterized by insufficient delivery of oxygenated blood to the myocardium, and this leads to a variety of sequelae like angina pectoris, which is intermittent heart pain due to ischemia. Can lead to a type of necrosis called myocardial infarction. And depending on where it affects the heart, it can lead to dysrhythmias if it affects any of the electrical conducting pathways. So, rhythms that are abnormal. Or even heart failure, which is the heart's inability to keep up with the metabolic needs of your body's tissues. And depending on where this coronary artery disease or CHD or coronary heart disease occurs, it can lead to sudden cardiac death. Now, in terms of the etiology of coronary heart disease, there are some known risk factors like atherosclerosis, which is a scarring and narrowing of arteries. Other possible microcirculation abnormalities can affect whether the heart gets a sufficient amount of blood flow. And this atherosclerosis causes a narrowing of the arterial lumen that can lead to ischemia through a variety of factors. It can lead to ischemia through the formation of a thrombus, because atherosclerosis can cause weakening of the vessel wall, and if that vessel wall tears, a thrombus can form. Coronary vasospasms can also lead to ischemia through excessive vasoconstriction of arterioles. And even endothelial cell dysfunction, where if the endothelium is thinned or weakened, this can lead to the formation of blood clots that can lead to ischemia. Now, we'll first talk about this method of atherosclerosis formation. Remember, atherosclerosis means scarring of the arteries, and this occurs when lipids are basically deposited into your vessel walls. Now, normally these lipids are transported as apoproteins, and depending on the type of lipoprotein that you're predominantly creating, it can be associated with a greater risk of atherosclerosis. And we'll differentiate that here in the next slide. Now, high-density lipoproteins, which can help transport lipids and cholesterol, are actually protective against atherosclerosis and can even help reverse and clear any sort of erythematous plaque. So what we see on this slide is the different types of lipoproteins that your body can create. We have chylomicrons, which, if you all remember going back to the digestive system, this is how lipids are first absorbed into your lymphatic system in that form. And these are more of a loose association of some apoproteins as well as lipids that are all bundled into this micelle structure here. Now, as these eventually get back to the bloodstream, we find that it's predominantly triglycerides and some cholesterol. And once in the bloodstream, these chylomicrons will eventually get to the liver, where the liver can convert chylomicrons into different types of lipoproteins, like very low density lipoprotein, intermediate density, low density, and high density. Now, these very low density lipoproteins are, again, mostly triglycerides, but they do have a high proportion of cholesterol here. And these very low density lipoproteins are the ones that are associated with coronary heart disease and atherosclerosis. Because it's more of a loose association of lipids, these are more likely to have a tendency to deposit in the vessel walls. And when these deposit in the walls of your blood vessels, they form a plaque that leads to an inflammatory immune response that actually leads to scarification and further injury to the arterial cell wall. Now, we consider this as the bad fat. Now, it's sort of a misnomer to call this fat necessarily, but when we talk about fat levels or triglyceride levels in someone's bloodstream, you want less of these very low density lipoproteins as a proportion of their total triglyceride levels. Some of the more healthy types of lipoproteins would be the high density lipoproteins. And these high density lipoproteins, or HDLs, these are considered like a good fat or a good type of lipoprotein or triglyceride. And what we find is that these actually have a lower proportion of triglycerides, some proportion of cholesterol, but they're also mostly made of protein. And it's these proteins that really stabilize the structure, and these high-density lipoproteins, or HDLs, are less likely to deposit in your vessel walls and also more likely to remove any kind of lipids like triglycerides or cholesterol from already existing plaques. So if someone can actually increase their HDL levels, it can reverse already formed plaques throughout their cardiovascular system. So when we talk about good fats versus bad fats, you want to avoid the LDLs, and LDLs are associated with certain dietary and lifestyle factors. What we find then is that these do have a certain amount of protein, but because they have a high proportion of cholesterol, triglycerides due to their protein content, these are more likely to break apart and deposit in your blood vessel walls. So the ones you definitely want to avoid: LDLs, IDLs, and very LDLs, so very low density lipoproteins. These are the ones that are more associated with cardiovascular disease like heart attack and stroke. Certain dietary and lifestyle factors can increase the proportion of HDLs in someone's bloodstream, and those are associated with better outcomes and lower risk factors for cardiovascular disease. Now, what this slide shows is a progression of atherosclerosis from sort of time zero over the course of years or possibly even decades. And what we see here then, and we'll start over on the left here, this is what a normal vessel should look like. So normally the blood vessel wall should have a nice smooth endothelium that's well organized with an underlying connective tissue in the intima layer. We should have an internal elastic membrane or lamina that separates the tunica intima from the tunica media. And the tunica media should have a nicely organized smooth muscle cell layer where these smooth muscles are very clearly and distinctly separated from the tunica intima. What we find, though, going from left to right, is the progressive development of atherosclerosis until what we see here is more of a highly diseased vessel. In fact, if you look here, you notice that there's less space in the vessel lumen on this end versus this end. And this is trying to show how with atherosclerosis that can cause a narrowing of the vessel wall. So looking on the left side here, what can convert a normal healthy vessel into one that can become atherosclerotic is the high presence of these LDLs. Remember, LDLs are the low density lipoproteins. And these LDLs, like I was mentioning earlier, are more often likely to deposit into the vessel wall because they're more loosely dissociated because they have lower density, and these lipoproteins can break apart and lipids can actually stick here in the tunica intima and cause streaking patterns throughout your cardiovascular system. Now what happens is that over time, if these lipids aren't removed, they can become oxidized, and oxidation here is more of just a normal process of these lipids being exposed to oxygen, and oxygen actually changes the chemical composition of these LDLs in such a way that oxidized LDLs cause an inflammatory response. So the cells here in the vessel wall can release cytokines like interleukin-1, and these cytokines can attract immune cells into the vessel wall in effort to remove these oxidized LDLs. Now, macrophages, as a consequence of this inflammatory immune response, can have chemotaxis and margination here into the vessel wall, where these macrophages will start to try to engulf all these oxidized LDLs within the tunica intima. Now, what this causes then is macrophages that are full of basically LDLs that it's trying to break down, they cause what are called foam cells. And these foam cells have a lot of difficulty, these macrophages have a lot of difficulty removing lipoproteins through endocytosis. And so what ends up happening is these foam cells just end up accumulating within the vessel wall here. Now, as a consequence of this inflammatory response, what happens then is that the cell, the tissues, as they try to repair themselves, some cells release additional cytokines and growth factors, and the overexposure of these cytokines and growth factors can actually lead to the migration of other cell types into the tunica intima that should otherwise not be there. So for instance, smooth muscle cells can start to migrate from the tunica media into the intima, where they try to basically stabilize this tissue. Now the migration of these smooth muscle cells leads to a thickening of the intima here, and these can also proliferate and thicken even further. Now, they can also secrete extracellular matrix, which acts to stabilize this plaque. And over time, if this plaque accumulates even further, it can limit blood flow due to tissue damage, where you can get little necrotic patches of tissue that are basically hypoxic, and these cells end up dying. And what this forms in is basically just a large plaque of dead cells and oxidized lipoproteins. Now, one thing that's good here is we can see that due to exposure to HDLs, you can get the efflux of cholesterol from these plaques. And by having an efflux of cholesterol, where cholesterol gets absorbed by HDLs that are floating by, you're effectively helping to diminish the size of this plaque, and it also makes the plaque more stable and reverses the damaging effects of that plaque. So, if someone actually can increase their HDL proportion, it can reverse the sort of atherosclerotic disease progression that we can see occurring on this slide. Now, in terms of some of the risk factors for atherosclerosis, if we back up here, we see that hyperlipidemia, or just sort of high lipid content in the bloodstream, is a risk factor. Hypertension, smoking, toxins, other hemodynamic factors, different immune reactions, even exposure to certain viruses can lead to the form of endothelial injury or dysfunction that can cause blood vessels to start to accumulate these LDLs. Now, there is a normal amount of lipoprotein accumulation someone can find in their bloodstream or blood vessels over the course of a lifetime. However, if too many LDLs accumulate in blood vessels, it can lead to atherosclerosis, which puts them at risk for, stroke, thrombus formation, embolisms, and all the sequelae that are associated with that. Now, in terms of the mechanisms of coronary atherosclerosis, what we find is that vulnerable plaques, which have a very thin cap and are considered more prone to high shear stress, they do have a large lipid core, which also makes them more vulnerable and unstable. But because their cap is thin, what this means is that there's not a lot of tissue between the atherosclerotic plaque and the inside of the blood vessel itself, which means it's more likely to tear, leading to a blood clot, which can lead to a thrombus and an embolus. Now, stable plaques, on the other hand, have more collagen and fibrin, and because they have more collagen and fibrin, the plaques themselves are less prone to high shear stress. They're therefore less likely to break apart from the rest of the tissue, and we call this more of a stable type of plaque, which also has a stable cap, and this cap is thicker and therefore less likely to tear. These stable plaques are associated with better outcomes of coronary atherosclerosis. Now, with respect to the coronary vessels, remember these coronary vessels are the ones that basically supply blood to the heart itself. So if it's coronary atherosclerosis, we're talking about scarring of the coronary arteries, which can lead to heart attack and possibly even total heart failure. Now, if those blood vessels do tear open or the plaques become large enough to totally or partially occlude the blood vessel, it could potentially lead to ischemia. Remember, ischemia is where you have a lack of blood flow downstream of a particular blocked vessel. And we define ischemia as where blood flow is diminished sufficient that oxygen supply can't meet the metabolic demands of the tissue that's downstream of that blockage. Now, coronary perfusion or blood flow can be altered by large stable plaques, which might just kind of occlude the vessel lumen, or platelet aggregation and thrombus formation. Otherwise, vasospasms can also lead to more of like a temporary form of ischemia, failure of autoregulation of the microcirculation, where a blood vessel might just not be diverted appropriately to the parts of the heart that need it the most, or even poor perfusion pressure, where if someone's blood pressure is too low, there may not be enough blood pressure to have blood flow through that blood vessel adequate to supply downstream tissues. Now, angina pectoris is a form of chest pain that's associated with intermittent ischemia. What this can kind of feel like is a burning, crushing, squeezing, choking kind of pain, and it can be referred. Remember, referred pain of the heart can be felt radiating down the medial aspect of the left arm or radiating up the neck and back or even jaw line. Now, this can result in inefficient cardiac pumping, which can lead to pulmonary congestion and shortness of breath. But what's important to note about angina pectoris is that this does not lead to any permanent myocardial damage. And this is why we call it intermittent ischemia, because after a certain period of time, that ischemia will go away and normal conditions are reversed or reverted back to, sort of that normal state in such that there's no permanent damage that occurs. Now, this differs from acute coronary syndrome because acute coronary syndrome is where you have chest pain that's more severe and lasts longer than typical angina. Acute coronary syndrome is associated more with plaque rupture and therefore acute thrombus development. This is similar to conditions like MI or myocardial infarct, where an occluded vessel could be completely blocked and therefore downstream tissue becomes necrotic, or unstable angina where the occlusion might be partial and that can lead to also some downstream ischemia that's less severe than myocardial infarct. Now, what we find then is that with acute coronary syndrome, some of the clinical features of this will, on an ECG or EKG, we find that as an elevated ST segment. So between the S wave and the T wave, you find a kind of an elevated segment that looks atypical from a normal EKG, and this is consistent with acute coronary syndrome or myocardial infarct. Now, there are other blood biomarkers that can be used for diagnosis, which we'll talk about here pretty soon. So what this slide is showing is a cross-sectional view of someone's heart, and this is the left ventricle here. This is the right ventricle over here. And if you look at first of all, the wall of the left ventricle is much thicker than normal. So the heart muscle is thickened dramatically, and this is indicative of someone who has hypertension chronically and their heart has to work even harder to pump blood out of the heart and throughout their body. Now, you'll find that the heart muscle looks fairly normal over here. It looks like normal muscle tissue or meat. But if you look here at this particular area of the heart, what we find that is an area of pallor within the muscle tissue. And this area of pallor, this is actually muscle tissue here. But what this is indicative of is muscle tissue that's ischemic, because without proper blood flow, then the muscle tissue starts to look more white and blanched, which is what we can see here. Now, this is sort of an area of necrosis that's occurred in this particular myocardial infarct, and you can see that in an area nearby, the tissue isn't necessarily blanched or pallor. It just looks more erythematic or red, which is more indicative of an inflammatory reaction that you would find sort of nearby that zone of necrosis. We call this the zone of stasis, where the tissue might have not necessarily died, but it just could be injured because it happens to be close to an area of ischemic tissue. Now, I would imagine that this individual didn't survive this particular myocardial infarct, because you can see that this whole aspect of their heart, which is the left ventricle and very important for pumping blood throughout the body, appears to be necrotic. Now, in terms of how acute coronary syndrome is diagnosed, we can see electrocardiographic changes. Like we said, the ST segment can be elevated. There are other elevations in specific blood marker proteins. Patients might have sort of subjective symptoms of severe crushing or excruciating chest pain that can radiate down the left arm, shoulder, jaw, or back. And this pain can be accompanied by nausea, vomiting, diaphoresis, and shortness of breath. Now, the reason why you get a shortness of breath there is in part due to this pain, but also because if the heart can't effectively move blood along, then blood starts to back up in the pulmonary circuit, which means it's inadequately oxygenated, and this can lead to a shortness of breath. Now, that elevated ST segment is what we mentioned earlier. We find here's the P wave, we have a QRS wave, but between the S and T wave, what we find is this elevated ST segment, which can be indicative of a myocardial infarct. What can also indicate myocardial infarct is an inverted T wave. So that post-infarct, what we find then is that T waves can be inverted for hours, days, weeks post-myocardial infarct. And this is sort of just indicative of an area of heart muscle tissue that is no longer functioning. Some serum markers that we can identify for ischemia and necrosis could be things like cardiac myoglobin, creatine kinase, or even troponin. What we find is that hours from infarct, what we find is that myoglobin can be observed in the bloodstream rising pretty dramatically. Remember, myoglobin is similar to hemoglobin, but you find it in muscle tissue, and it's involved with binding to and storing oxygen within muscle tissue. If you're finding a lot of cardiac myoglobin in the bloodstream, that's abnormal, and that suggests that cardiac muscle cells have now lysed or burst open, and now you're finding that protein in the bloodstream. Now, what can occur later then are rises in troponin. We know that troponin is one of the proteins that's necessary for cardiac muscle cell contraction, and so troponin is also a serum marker for ischemia and necrosis in the heart, or even creatine kinase, or CK. Creatine kinase, remember, is the enzyme that adds phosphate to creatine phosphate, and it's one of the enzymes that can help your heart store energy for later use. But you can actually look at all three of these as biomarkers for the degree of ischemia and necrosis that may have occurred in someone's body. In terms of the treatment for acute coronary syndrome, ultimately what we want to do is actually decrease the myocardial oxygen demand. If we can get the heart to work less strongly, then we can actually help that surviving tissue last longer. And this is achieved through sympathetic antagonists to slow your heart rate down or prevent overcontraction of heart muscle. Adequate rest, heart rate control, pain relief, and afterload reduction, which is afterload is ultimately just blood pressure or diastolic blood pressure. So if you can reduce someone's diastolic blood pressure, then it's easier for the heart to eject blood and get blood moving downstream. Now, what we can also do then is increase the available oxygen to the myocardium. And this is achieved through thrombolysis. So there's different drugs that we can use to break apart pre-existing blood clots. That way, if there is any ischemia, that we can achieve adequate blood flow downstream. Otherwise, we can do angioplasty, which is where you can go into a blood vessel and place a stent, and that basically opens up an occluded vessel and allows blood to adequately flow. Or even coronary bypass grafting, where you might take a small vein out of someone's leg and then graft that onto the heart around a blockage. That way blood can actually flow around that blockage through basically a bypass. One thing that's important, though, too, is monitoring and managing any kind of complications here. So early detection of the ischemia is important, and management of any potential dysrhythmias is also important to improve outcomes in these patients. Now, what this slide is showing is just sort of a summary of the different treatment options for acute coronary syndrome. So there's different drugs that can enhance enzymatic digestion of thrombus, and that can help break apart a blood clot and allow blood to move and help reduce any ischemia that may have occurred. We can actually have physical disruption of plaque, where we can go in there and basically remove plaque. Placement of a stent, and the stent can actually basically just open up that vessel and allow blood to flow. Or even coronary artery bypass, where if we do have a blockage, we can actually just graft a new blood vessel onto the existing vessel to get around that blockage, and that way we can improve blood flow through a new vessel to get around that blockage. Now, chronic ischemic cardiomyopathy is a form of heart failure that develops more insidiously. And if y'all remember, the word insidious means that it sort of develops without any dramatic signs and symptoms. And this is a form of heart failure then that would lead to progressive ischemia and myocardial damage, where you don't have any signs and symptoms until there's some really severe damage that's occurred. Now, you typically find chronic ischemic cardiomyopathy occurring in people who have a history of angina or myocardial infarction, and it appears to be more of a consequence of slow, progressive myocardial apoptotic death, which comes from chronic ischemia. And this can actually occur in areas that might be scattered throughout the myocardium. And so one of the ways that this could be insidious is that if smaller blood vessels that only supply blood to very small areas of the myocardium become ischemic, it may not lead to any outward signs and symptoms right away, But due to a more widespread form of ischemia in smaller vessels, over time, you can get apoptosis and more of a slow death of the muscle that eventually can lead to heart failure. This is more common in older adults, and often the prognosis is poor because by the time there's any signs and symptoms of disease, there's pretty extensive damage that's already done. Now, in terms of endocardial and valvular disease, remember the endocardium is the tissue that lines the inside of the heart. And it's also made of something like a tunica intima. It's basically a smooth muscle. It's a single layer of simple squamous cells. And it turns out the valves, or heart valves, like your tricuspid and bicuspid and aortic and pulmonic valves, are also mostly made of something that's like an endocardium. So that when we talk about endocardial disease, it kind of goes hand in hand with valvular disease. And this can be achieved or caused by inflammation and scarring, calcification of tissues, or even some congenital malformations. Now, this is important to note because if someone's valves are damaged, it can lead to altered hemodynamics or blood flow through the heart, which may increase myocardial workload. If blood's backflowing because a valve isn't working properly, then the heart muscle has to work harder to allow blood to flow. Now, there's some different terms we want to define before moving forward. The first being stenosis. So stenosis is where we have sort of a narrowing of a particular passageway. And so when we refer to stenosis with respect to valves, this is failure of a valve to open completely, which means we have a more narrow passage for blood to travel through. And this results in extra pressure or work for the heart to pump that blood through a narrow passageway because the valve, for whatever reason, whether it's acquired or congenital, doesn't open properly. Regurgitation is also insufficiency, and it's an ability of the valve to close completely, and this can lead to basically a backflow of blood, which can actually cause extra sort of work on the heart to adequately achieve blood flow. Now, murmurs are common with valvular disorders, and a murmur is basically going to be where you have an abnormal heart sound. So in the last chapter, we talked about how we had S1 and S2, where S1 was the closing of the AV valves, S2 was the closing of the semilunar valves. And if those valves don't have a nice, solid, clean lub or dub, if they do la-da-da-da-da or dub-ba-ba-ba-ba, we call that a murmur, and this can be indicative of valvular disorder. So the first type of endocardial and valvular disease we'll talk about is mitral stenosis. Remember, stenosis means narrowing of the mitral valve specifically. So mitral valve is also called the left atrioventricular valve. So if you have the stenotic or narrowing of this particular valve, what we find then is that blood flow from the left atrium to the left ventricle is impaired during ventricular diastole because while the atria are also in diastole, and they're filling with blood, the atrioventricular valve or mitral valve could be open and therefore filling the ventricle with blood. But then even during atrial systole, when the atria are forcing blood into the ventricle, blood's also being forced through this particular valve, or the mitral valve. What we find then is that due to narrowing and stenosis of this particular valve, we have increased pressure from the left atrium, which leads to left atrial chamber enlargement and hypertrophy. This can lead to pulmonary hypertension too, because we might have a backflow of blood to the lungs, and that can lead to right ventricular hypertrophy because the right ventricle might have difficulty pumping blood to the lungs, and this could also progress to right-sided heart failure. So in the next chapter, we'll talk about how right and left-sided heart failures can be interconnected, but it's just an interesting association to consider here. What this sounds like then is a low-pitched, rumbling diastolic murmur with open snap. Atrial dysrhythmias can occur. You're also more prone to atrial clots because of stasis of blood. It can also lead to exertional dyspnea, and dyspnea means shortness of breath. And that makes sense, how if blood's not being effectively pumped along, how that can lead to shortness of breath upon exertion. So if we measure pressure changes between the left ventricle and left atrium during a normal cardiac cycle, what we find then is that you should expect to see that when the left atrium contracts and pressure in the left atrium rises, You should also see pressure rise correspondingly in the left ventricle as long as the valve is open enough for blood to flow from the left atrium to left ventricle. So that during ventricular filling and while the atria are contracting, these pressures should be matched. But what you're seeing though is a disparity. You're seeing that pressure is actually much higher in the left atrium versus the left ventricle, and this is really going to indicate and make clear that there's a narrowing of the valve, which is limiting blood flow or communication of blood from the atrium, left atrium to the left ventricle. And that's why these pressures are so different. Now, this differs from mitral regurgitation because regurgitation meant where the valve doesn't close completely. And this causes a backflow of blood from the left ventricle to left atrium while the ventricles are contracting. Now, this causes the left atrium to also dilate and hypertrophy due to extra blood being forced back up into the atrium. And this could progress to left-sided heart failure if left untreated. What this sounds like is a high-pitched pansystolic blowing murmur. You can see these V waves that can occur with measuring blood pressure, as well as chronic weakness and fatigue. So if we can measure blood pressure in the left atrium and left ventricle, what we find is that, yeah, okay, so the left atrium and left ventricle pressures are typically, they're closely matched, which that part is normal. But what about during ventricular systole? While the ventricles are increasing their pressure and starting to try to force blood out of the heart, we also see a corresponding rise in pressure in the left atrium while the atria are in diastole. And this doesn't make sense. You shouldn't expect to see a really rapid rise in pressure of the left atrium while the left ventricle is contracting. And what this indicates then is that there's a backflow of blood. Because if blood's flowing back through an incompletely closed valve, then that means that blood pressure is going to rise in the left atrium during left ventricular systole. And that's exactly what we see here. Now, you'd imagine then that due to this backflow of blood, cardiac output would be diminished because of lower stroke volume and lower ejection fractions. And also due to a backflow of blood, the left atrium would start to balloon outward because it's starting to have increased pressure. You can also expect that blood might flow back to the lungs and lead to a little bit of pulmonary congestion. Now, this differs from mitral valve prolapse because prolapse is where you have a displacement or ballooning of the mitral valve leaflets into the left atrium during ventricular systole. So mitral valve prolapse is more severe than mitral regurgitation because not only do the valves incompletely close, rather the valve leaflets blow back into the left atrium. So they actually don't close at all. What we find is that epidemiologically, women are more affected than men by mitral valve prolapse. It can be asymptomatic, but what this can sound like is a mid-systolic click or systolic murmur, and palpitations can occur. You might see some rhythm abnormalities, dizziness, fatigue due to limited blood flow to the systemic circuit, dyspnea because of pulmonary congestion, chest pain because of the additional, sort of stress your heart has to overcome, as well as depression and anxiety due to the limited blood flow to the brain. Now, what this looks like then is if you can look at a mitral valve prolapse and dissection of someone's heart, what we can see then is that the left ventricular myocardium looks thicker here because the heart's having to work harder to pump blood to the systemic circuit. And also the leaflets are starting to blow back into the left atrium here. Also, the left atrium's ballooned out because of backflow of blood. So it's similar to mitral regurgitation, but this is where an entire leaflet of the valve can actually blow back into the atrium. Now, aortic stenosis is going to be where you have a narrowing of the aortic valve, and its predominant cause is age-related calcium deposits that can accumulate on the aortic cusps. And if these cusps become calcified, then effectively the valves can't open properly because they're more stiff. So this results in obstruction of aortic outflow from the left ventricle. So what this leads to then is that the left ventricle has to work harder, so it becomes hypertrophied, or the muscle becomes thicker. And this may result in ischemia or even left-sided heart failure. What this sounds like is a crescendo-descendo murmur with a prominent S4 sound. So we do have an additional S4. Then other signs and symptoms could be things like syncope, fatigue, and angina. So if we can look at pressure changes then between the left ventricle and aorta, we know that during ventricular systole and while ventricular pressure rises, once that aortic valve opens, you should expect that aortic pressure and left ventricular pressure should be totally matched, because then blood from the ventricle is now flowing into the aorta. But what we find, though, is there's actually a discrepancy between left ventricular pressure and aortic pressure. And instead, what we see is that there's a sort of a resistance of pressure increase in the aorta, and this is due to a narrowing of the aortic valve. So if the aortic valve can't open properly, then effectively blood is not being ejected from the left ventricle sufficient that you can get a proper ejection fraction, so that we see slower rises in pressure in the aorta, so that ejection fraction is affected, stroke volume is affected, and therefore cardiac output would also be limited. Now, because the left ventricle needs to produce tremendous increases in pressure just to force blood out through the aorta, it puts extra stress on the left ventricle, and that can lead to cardiomyopathy, ischemia, or even left-sided heart failure. Now, in terms of other diseases of the endocardium, one we'll talk about is rheumatic heart disease. So rheumatic heart disease is a consequence of a strep or staph infection, and it's an acute inflammatory disease that follows this particular infection. It's damage that occurs where an accumulation of antigen-antibody complexes, so it's more of like a type 4 hypersensitivity, where the individual's own immune system starts attacking those tissues that have now accumulated antigen-antibody complexes. So we have a lot of antibodies against these streptococcal antigens that can accumulate in connective tissues like joints, even your heart and skin. So you actually can get a sort of rash that can occur with rheumatic heart disease and rheumatic fever. But because these antigen-antibody complexes accumulate in the heart, we do get that type 4 hypersensitivity that leads to damage of the endocardium, where those complexes have now accumulated. Now, it occurs mainly in children. Children have a tendency to be more prone to these sort of infections like strep. What this can present as is fever, sore throat, joint inflammation, or even things like involuntary movements. And a certain distinctive truncal rash that we'll talk about when we get to the skin. Now, this differs from infective endocarditis, because infective endocarditis is where you actually get invasion and colonization of the endocardium by living microorganisms. Now, this can be caused by also strep and staph, kind of like rheumatic heart disease, but the difference here is that it's not due to hypersensitivity. You can get endocarditis due to infection of the endocardium by these particular microorganisms. Now, acute infective endocarditis has more of a poorer prognosis, and you see this more commonly in intravenous drug users, because they're potentially using dirty needles and introducing staph and strep into their bloodstream. They're more likely to get acute infective endocarditis. Otherwise, there's subacute infective endocarditis where there are some different predisposing risk factors, but this can have better outcomes. Now, myocarditis is going to be an inflammation of the myocardium or heart muscle. So it's characterized by this inflammation, leukocyte infiltration, and possibly even necrosis of cardiac muscle cells. Some causes include microbial agents, so direct infection of the myocardium, or immune-mediated diseases, or even physical agents that might affect the heart muscle. Usually this relates to viral infections, so viral etiologies are the most common, and it's characterized by left ventricular dysfunction, where we might find like flabby muscle with patchy or diffuse necrotic regions, and general dilation of the four heart chambers, where due to necrosis and damage of the heart muscle, the heart chambers become larger and more flabby, and it's a type of myocarditis. Now, this differs from cardiomyopathy, and this is classified by functional impairment. Now, the primary cause of cardiomyopathy is where you have a dysfunction of an unknown cause. Secondary form of cardiomyopathy where there's a known cause. And some functional classifications of cardiomyopathy, we have dilated, hypertrophic, and restrictive cardiomyopathies. A dilated kind of cardiomyopathy is where you have enlarged ventricles, and you might see this with the last form of myocardial disease we talked about, like the myocarditis would be a form of dilated cardiomyopathy. Hypertrophic cardiomyopathy could come about from increase in the size or sort of thickness of the myocardium. And we talked about how hypertrophy can come about from stenosis of different types of heart valves. Or restrictive cardiomyopathy could occur where you have rigid ventricles due to an accumulation of scar tissue. And if the ventricles can't move as well, then you have inadequate filling or even pumping of blood because the myocardium is more restrictive and less flexible. Now, pericardial diseases can be sequela of other disorders like infection, trauma, metabolic derangement, or even neoplasia or growth of cells. And the first type of pericardial disease we'll talk about is the pericardial effusion. And this pericardial effusion is where you have an accumulation of non-inflammatory fluid in the pericardial sac. Now, pericardial effusions can be made of serous fluid, they can be made of blood, they can be made of a mixture of serous fluid and blood, which we call serosanguineous, or they can even be chylous fluid. Remember, chyle is fatty lymph, so sometimes lymphatic fluid can start to accumulate in the pericardial sac so that we can get a chylous effusion. Now, it's non-inflammatory, so these effusions won't cause inflammation of the pericardial sac, but an excessive amount of effusion can lead to what we call cardiac tamponade. Now, cardiac tamponade is where you have fluid accumulation in the pericardial sac, and this can lead to such external compression that the heart chambers can't fill normally. So filling is impaired due to an excessive increase in external compression on the heart from fluid accumulation. So some manifestations of cardiac tamponade can be things like reduced stroke volume, compensatory increases in heart rate, pulsus paradoxus, hypotension or low blood pressure, distended neck veins due to congestion of blood, muffled heart sounds, and the treatment for this is pericardiocentesis, or basically aspiration of that excess fluid using a needle. Acute pericarditis is where we have, basically just inflammation of the pericardium. Now, most cases are idiopathic and can be viral, so you can't treat this with an antibiotic. It's typically uncomplicated and can resolve spontaneously. If it is a complicated form, what we find then is that it could involve pericardial effusion, it could be persistent and recurrent inflammation, and this may require hospitalization due to cardiac tamponade or even so much inflammation that you start to see damage to the heart or heart muscle tissue. Now, it typically presents as chest pain due to inflammation, fever, and leukocytosis from infection. You can get some malaise or sort of tiredness from inflammatory molecules that can be released. Tachycardia can result from that cardiac tamponade, and this may result in friction rub if there's a lot of inflammation, and that can also relate back to the chest pain if there's an excessive amount of friction that occurs. And so, if it's very painful, this is why it can require hospitalization. Now, chronic pericarditis, we have two main forms. We have adhesive and constrictive pericarditis. Adhesive mediastinal pericarditis is where you have pericardial sac that's destroyed, and the external aspect of the heart therefore adheres to surrounding mediastinal structures like the thymus or the trachea or the esophagus or even the nearby lungs. So if the heart starts to adhere to these nearby tissues, it can put stress on those tissues and also limit effective heart movement and heart function. So that's adhesive mediastinal pericarditis. This differs from constrictive pericarditis because this is where the pericardial sac becomes dense. This density can be a result of chronic infection and inflammation, where you can get hypertrophy of the pericardium. And it's constrictive because this pericardial sac is therefore non-elastic, fibrous, and scarred. And by having a thicker, sort of tough, more rigid and immovable pericardial sac, it causes constriction of the heart and makes it more difficult for adequate filling and pumping of blood. Now, we're going to move on to last in this chapter, talking about the congenital heart diseases. Remember, if it's a congenital heart disease, this is something that develops prenatally. And this is where it's an abnormality that can be present at birth. Now, different congenital heart anomalies can result in different pathological processes like shunting of blood through abnormal pathways or obstruction of blood flow through narrowing of certain passageways. So the first type of congenital heart disease we'll talk about is atrial septal defect. Now, the atrial septal defect is where we have an additional hole in the septum that separates the right atrium from the left atrium. Now, under normal fetal circulation, what we find is that you do find a foramen ovale, or hole, that allows for the shunting of blood from the right atrium to the left atrium, because in the fetus you don't necessarily need blood to flow to the lungs because the fetus is immersed in a fluid environment. It's not using its lungs for oxygenation. So atrial septal defect is going to be where this foramen ovale fails to close adequately after birth. And we call this a patent foramen ovale, or atrial septal defect, where you have a large hole that remains between the left and right atrium. It turns out that this atrial septal defect, or ASD, affects approximately 10% of the population. And of those 10% that are affected, many of them have no signs or symptoms. But if the atrial septal defect is large enough, this can lead to a reduction in blood flow through the pulmonary and systemic circuits, and things like dyspnea and shortness of breath, possibly even cyanosis. Now, ventricular septal defect is where we have a defect of the ventricular septum, and therefore a hole that connects the left ventricle to the right ventricle. What this typically leads to is an accumulation of oxygenated blood from the left side of the heart and mixing of that blood with deoxygenated blood into the right side of the heart. Due to this mixing of blood, it's going to limit the ejection fraction, or stroke volume, of blood that's going to leave through the systemic circuit. And so they're going to have diminished cardiac output, and all of the signs and symptoms you should expect to see with that. Now, depending on the size of these ventricular septal defects, it can lead to a varying amounts of cyanosis in a newborn. But in either case, this ventricular septal defect needs to be repaired in order for adequate blood flow. Now, a patent ductus arteriosus can occur when basically this ductus arteriosus that connects the pulmonary trunk to the aorta doesn't close adequately after birth. We know that part of the fetal circulation is shunting of blood away from the lungs, or away from the pulmonary circuit, directly into the aorta through what we call ductus arteriosus. So that in a normal fetus's circulation to the heart, we should see blood flow from the pulmonary trunk directly into the aorta. But if this ductus arteriosus, which is this little shunt, if that fails to close after birth and it remains patent or open, then what we can find then is actually a backflow of blood from the aorta through the ductus arteriosus back into the pulmonary circuit. And what this leads to then is sort of a limited cardiac output, because now blood's actually flowing back into the pulmonary circuit instead of continuing on through the systemic circuit. This differs from the coarctation of the aorta, and this is where you actually have sort of a narrowing of the aorta, or stenosis, and this also limits blood flow downstream through the systemic circuit, and also puts excess stress on the left side of the heart to overcome this stenosis, or narrowing of the aorta. Now, Tetralogy of Fallot is where you have pulmonary stenosis, ventricular septal defect, and those together call this Tetralogy of Fallot. And this is where we actually have a mixing of blood back and forth. Pulmonary stenosis here then can lead to more blood actually being pumped into the left side of the heart from the right ventricle, instead of being able to continue out through the pulmonary trunk. Because we have this overriding aorta, the aorta can also pick up deoxygenated blood from the left ventricle, so you get a mixing of blood. This leads to an excessive amount of cyanosis that can be life-threatening. So this is something that also needs to be repaired shortly after birth, or even in utero. Now, we do see some right ventricular hypertrophy that can occur because the right side of the heart has to work harder to pump blood and overcome the pressure that's simultaneously generated by the left side of the heart. Now, transposition of the great arteries occurs when essentially the pulmonary trunk and the aorta get switched. So what we see here then is that the right ventricle is now actually connected to the aorta, and the left ventricle is now actually connected to the pulmonary trunk. Now, due to this transposition or swapping of these vessels, now what you end up with then are two uncommunicating circuits of your cardiovascular system. Because if you think about it, the left side of the heart receives blood from the lungs. But if the left ventricle is pumping blood back out through the pulmonary trunk to the lungs, that means that blood that's going to and from the lungs is never really reaching the rest of the body. So we call this sort of a non-communicating circuit. So it's just blood being pumped to the lungs and back to the heart, and to the lungs and back to the heart, without actually that oxygenated blood ever reaching any other body tissues. Now, what this means then for the right side of the heart, because the right ventricle connects to the aorta here, in this example, it's going to pump that deoxygenated blood back out to the aorta and through the systemic circuit, whereby that blood is then returned through the venous system back to the right side of the heart. So again, with this particular circuit, now it's just that deoxygenated blood that never communicates with the lungs, so you get an uncommunication or discommunication of these two circuits. This is not survivable, obviously, because if the blood that needs to be oxygenated never reaches your lungs, then your body's tissues aren't going to be able to survive that. So this is the type of thing that needs to be repaired shortly after birth or even in utero. Now, this differs from Truncus Arteriosus, which is effectively a merging of the pulmonary trunk and aorta into one large vessel. So you get the mixing of oxygenated and deoxygenated blood, and this also co-occurs with a ventricular septal defect. So it's almost as though instead of having two separate heart chambers, it's almost as though your heart has one large fused ventricle that then pumps and mixes oxygenated and deoxygenated blood into one large vessel, which then could branch out into an aorta or pulmonary trunk. So it's a very ineffective way for blood to be pumped throughout the body, and this causes a pretty severe amount of cyanosis. And this would also require surgical intervention.